Bangladesh Health Systems Financing Overview and Critical Analysis. Bangladesh, a densely populated South Asian country with a GDP of over $302 billion. Bangladesh was restatused to lower middle income in 2015. With over 163 million people, the country is in the middle of an epidemiological and demographic transition. It's important to know that Bangladesh suffers from a high level of both poverty and corruption. The 1972 Constitution affirms all citizens are entitled to basic medical care. In practice, the statutory health care is highly subsidized by the government in efforts to create a Beveridgean system, but the citizens are still responsible for out-of-pocket payments. In this presentation, I will tell you how and why the healthcare financial system isn't equitable, and recommendations on how to fix this. Bangladesh has a pluralistic health system. The actors are the government, nonprofit private, for-profit private, and international development organizations. The health system is highly centralized, and the Ministry of Health and Family Welfare is the central body, as you can see in both Tables 1 and Table 2. The Ministry of Health and Family Welfare is where decisions are made, policy is created, and pharmaceuticals are managed, among other things. Ministry also governs public and private health sectors, as well as the country's primary, secondary, and tertiary public services. The statutory countrywide healthcare system provides primary, secondary, and tertiary medical care in the public health sector. The subsidized care is provided to all citizens of Bangladesh, not inclusive of non-citizens. Primary outpatient care is offered throughout the country, but secondary and tertiary care are only offered starting at the Upazila or sub-district level, and tertiary care can only be found at medical colleges and specialty hospitals that may be inaccessible to those living in villages. Table 3 provides a visual of how access to care can be an issue for populations living in rural Bangladesh. In Bangladesh, the 6 main sources of health financing are out-of-pocket, government, foreign voluntary private firms, nonprofit and NGOs, and voluntary insurance schemes. The 2 main sources of the 6 are government schemes and out-of-pocket payments, of which the expenditure in 2015 for the latter is far greater with 67%, as shown in Figure 2, while the government financed only 23%. To draw a comparison, Table 4 indicated that from 1997 to 2015, the out-of-pocket payments have grown much faster than the government expenditure has. Let's talk a bit more about financing. In relative amounts, the total health expenditure in 2015 as a percent of the GDP was 2.98%. Divided into public and private sector expenditures, the entire private sector, as indicated by the pie chart, spent 77.26% of the total health expenditure. On a micro level, the total health expenditure per capita was $37. To additionally break down public and private expenditures, let's take a closer look. In Figure 4, the Ministry of Health and Family Welfare spent the most with over 93%, while the other ministries and local government municipalities and corporations also contributed, but far less. As indicated in Figure 5, the greatest percentage was financed by private household out-of-pocket costs, as you know, with international development agencies bringing just over 9%, followed by nonprofit and NGOs and other private firms. Now let's talk about how things are organized in the health financing system. The organization of the system is complex, as you can see in Table 5, as there are many funding sources and financing intermediaries. Let's have a closer look at the public financing system and the revenue receipt you see in Figure 6. Tax and non-tax revenues are collected by the Ministry of Finance. The majority of people who pay income taxes have it withheld from their salary, as in Figure 7. However, more revenue comes from indirect taxes than direct taxes, since only a small portion of citizens pay direct taxes. This is for a few reasons. Firstly, anyone making below the threshold, as indicated in Table 6, will pay nothing. Secondly, many workers are informal workers, and they're paid in cash. So, unless they voluntarily pay, taxes won't be collected. Third, in fiscal year 2014 to 2015, only 1.8 million people actually had tax ID numbers in Bangladesh. And out of those, only 1.2 million actually paid their annual income taxes. This means there are millions who aren't paying their share and many more millions who have no tax ID, but may be making it over the threshold. And one reason for this could be the low tax effort in Bangladesh, which we will talk more about later. The Ministry of Finance prepares the budget with the government income as seen in Figure 9, using the medium-term macroeconomic framework. This provides revenue targets for each ministry as seen in Figure 10, and it's at this time that the health fund pooling emerges since there are no earmarked taxes. Looking again at the flow of funds, we know now where the public funds are coming from that contribute to the public sector statutory healthcare. The dependency on the indirect taxation, such as the VAT tax, has a possibility of being regressive since there is more financial burden on the poor. Although, as can be seen in Figure 11, the gap has narrowed since 2005. Looking now at Figure 12, which shows the overall share of health payments by quintile in 2010, you can see how the health expenditure decreases as you go from the lowest quintile to the highest quintile. The lowest quintile households were paying 7%, and the highest quintile paid just over 3%. Household out-of-pocket payments have a Kakwani index of negative 0.2005, which is highly regressive, indicating that payments were more concentrated among the poor. In total, the health financing system based on gross consumption and spending is negative 0.1917 on the Kakwani index, meaning that it's also highly regressive. I equate this regressivity of the Bangladeshi healthcare system with an inequitable system. Inequitable, unforeseen issues caused by out-of-pocket payments range from selling belongings, inability to maintain nourishment, dropping out of school, medical debt, bankruptcy. The highly centralized health system causes clinics and hospitals to go without proper funding, management, staff, supplies, pharmaceuticals, and on-site decision makers. Poor people are especially vulnerable to abuse and financial exploitation by the health system. They don't have options, and everyone knows. Non-citizens, asylum seekers, and immigrants deserve health equity, not by their status of ability to pay or inability to pay. Corruption slithers through all levels of the health system. There's a serious lack of ethical oversight and moral codes to follow. Based on the strengths and weaknesses of the overall system, it should be proposed that they make efforts towards a Beveridgean system. In order to do so, the public expenditure must increase. Figure 14 shows the opposite might be happening. Firstly, we need to return to the concept of tax effort. As seen in Table 10, only a small proportion of people pay tax. Table 11 displays how Bangladesh compares with other countries in South Asia in terms of tax revenue, as percentage of GDP. This reflects the government's tax efforts in enforcing the civic duty of tax paying after a certain threshold. Making more fiscal space can also incorporate changing the policy on the indirect VAT tax. By charging a VAT tax on products or services that are basic necessities, it becomes very regressive. Instead of charging a VAT tax on basic necessities, charge instead on goods that more middle and upper class consumers purchase. The VAT tax revenue will be higher and it will be progressive rather than regressive. The third idea to create more fiscal space is to enforce the wealth tax and continue to raise the wealth tax. As seen in Table 12, the wealth tax is highly progressive. So to recap, it's recommended that Bangladesh progress towards a Beveridgean system after more fiscal space has been obtained. The next step would be decentralization so that lower-level facilities can make crucial decisions about management, organization, supplies, drugs, staff, and conduct. It's vital that courses in medical ethic principles are added to all curriculums for healthcare and administration professionals. The international development community must prepare a financial oversight coalition that works with other governments to enforce transparency and minimize the corruption. And finally, government funds created with above suggestions can also be used to subsidize tuition for all nurses and doctors for 5 years' work in rural Bangladesh. This concludes my presentation. Thank you very much.